Hello all, welcome to the another session that is on a normal cardiac physiology. The human heart works as a mechanical and electrical organ. To perfuse the body with the blood, the mechanical and electrical component of the heart must work in a coordination. The mechanical component pumps the blood and the electrical component controls the rhythm. So in this session, we just recall the normal cardiac physiology. Electrophysiology of cardiac rhythm. Electrical activity in the heart leads to a rhythmic cardiac contraction, and it starts with the impulse formation, and that is followed by impulse transmission. There are two types of cardiac tissue. They are known as a conducting tissue and a non-conducting tissue. Conducting tissue includes node, heavy node, bundle of His and Purkinje fiber, while non-conducting tissue include atria and ventricles. Now, how electrical impulse which is formed in a pacemaker tissue and it transmitted towards a non-pacemaker tissue. So the electrical sequence which is generated in a heart is as the impulse which is formed in a node that can be spread throughout the atria and it stimulates the atrial tissue, and then after it reach towards a AV node. From AV node, impulse pass on to the bundle of His and then through Purkinje fiber for both right as well as the left side and stimulate the ventricles, and that stimulation of ventricles can initiate the contraction of heart. So there are different tissue in a heart. The responses which were generated in a different tissue, they were categorized as a fast response and a slow response. So in a fast response, tissues which are involved like atria, ventricles, bundle of His and Purkinje fiber, where the rate of depolarization is very fast, and the ion channel which is responsible for the generation of phase 0 is an opening of fast sodium channel, and there the threshold potential is around minus 60 to minus 70 millivolt, while the tissues which generate a slow response, basically those tissue, they are known as a primary pacemaker tissue, as a node and a AV node. Their rate of repolarization is very slow, and that is generated because of opening of L type of calcium channel. So the phase 0 is mainly produced through opening of L type of calcium channel, and their threshold potential is around minus 45 to minus 55 millivolt. So different tissue, whether they were the fast tissue or a slow fast response or a slow response, whether they are the pacemaker tissue or a non-pacemaker tissue, the action potential which is generated in the both the type of tissue are different. So it is necessary how this action potential is generated. So first we discussed about the action potential in a pacemaker tissue. In a SN node, there are three ion channels are mainly important to generate a pacemaker action potential. At the end of repolarization, or we can say that at the end of phase 3, where the membrane potential is around minus 60 millivolt, then there is a starting of phase 4, and that phase 4 is known as a diastolic depolarization. So the starting of phase 4 where the membrane potential is around minus 60 millivolt, at that time there is an opening of sodium channel. Opening of the sodium channel can increase the membrane potential towards a minus 50 millivolt. When it reaches towards a minus 50 millivolt, there is the opening of another type of channel, that is the T type of calcium channels were opened up, and that opening of this T type of calcium channel can further depolarize the membrane, and it increase it till it reach towards a threshold potential. Once it is reached towards a threshold potential, that is the starting of phase 0. So phase 0 depolarization is caused mainly by the opening of L type of calcium channel. Opening of this calcium channel and both other channel, T type of calcium channel and the IF current, both are now in a closed state. Opening of L type of calcium channel, that movement of calcium through this channel is not rapid, so it is a slow current, and that is why the rate of depolarization is, or we can say that the slope of phase 0 is slower. Then after, once the phase 0 is over, when the channel is become in a L type of calcium channel in an inactive state, by that time there is a starting of phase 3, and that phase 3 is known as an repolarization, where there is an opening of IF, there is an opening of potassium channel. Opening of this potassium channel leads to efflux of potassium ion, and that leads to repolarization of membrane potential, and that repolarization is also followed by hyperpolarization. So uh, once the membrane potential is reached again around minus 60 millivolt, there is a again starting of phase 4, or there is a starting of diastolic depolarization. So in a pacemaker tissue, action potential, where the mainly three type of calcium channels are responsible: sodium channel or IF current, calcium channel, both T as well as the L type of calcium channel, and the potassium channel for a repolarization. While in a non-pacemaker action potential, they are not a pacemaker tissue, so they required any stimulate to generate a action potential, in which the membrane potential is around minus 90 millivolt, and the threshold potential is around minus 70 millivolt. Phase 0 is known as a rapid depolarization, and that rapid depolarization is basically because of opening of sodium channel, and that sodium channel are fast sodium channel. Once it reach around plus 50 millivolt, there is a inactivation of sodium channel, and there is a opening of potassium channel, and that opening of potassium channel and that phase is known as a phase 1, and that is a rapid repolarization. And by that time, once the membrane potential is reaching towards a 0 millivolt, there is a opening of calcium channel. So phase 2 is known as an prolonged plateau phase, that is due to entry of calcium ion, as well as there is a outward movement or efflux of potassium ion. So there is a plateau state is generated. Within a short period of time, calcium channel become inactivated, they are in a closed state, and now the second phase of repolarization is started, and that phase is known as in phase 3 of rapid repolarization. Now the only potassium channel is in an open state. Once it is reached around minus 90 millivolt, phase 4 is started, and that is known as a resting phase, during which membrane sodium potassium pump gets activated, and that tends to restore the ionic disturbance towards the resting pattern. So here you can see that again sodium, potassium and calcium channel are responsible in a non-pacemaker tissue as well. But the difference is that in a pacemaker tissue, the Phase 0 is mainly responsible through L type of calcium channel in a non-pacemaker tissue. Phase 0 is opening due to opening of fast sodium channel. Now there is an important terminology that is about the refractory period. After an action potential, cardiac cell is unable to initiate another action potential for some duration that is slightly shorter than the total duration of action potential. This period is known as a refractory period. That refractory period is categorized in a different type. First type is absolute refractory period. During this phase, the cardiac muscle does not respond to any stimuli of whatever the strength of stimuli is there. And that is basically during phase 1 to the phase 2. So no stimuli are able to stimulate the tissue. So that is a absolute refractory period. Then there is a relative refractory period. This is a period when a higher strength of stimulus can excite the cell, and that also result in a propagation of action potential. So that is from mid phase 3 to the end of phase 3. So any higher strength of stimuli are able to stimulate the cell, and there is a another action potential is started, and this is a main target to alter the cardiac rhythm, or we can say that to alter the cardiac rhythm in a development of cardiac arrhythmia. And there is a effective refractory period. It is a short interval followed by the absolute refractory period, where the stimulus of higher strength can excite the cell but does not propagate any action potential. So the difference between effective refractory period and relative refractory period is that in a relative refractory period, impulse is transmitted to generate action potential, while in case of effective refractory period, it can excite the cell but the impulse is not propagate any generation of action potential. Difference in a duration of effective refractory period in a fast channel and in a slow channel. In a fast channel action potential, where the effective refractory period is shorter than the action potential duration. The reason for that, fast channel, sodium channel are mainly responsible to generate a fast response, and as they generate a rapid depolarization, same way they also repolarize very rapidly. So the sodium channel recover as a voltage dependent manner, so they repolarize rapidly, so their effective refractory period is shorter than the action potential duration. While in a slow channel action potential, their effective refractory period is more than the action potential duration. For a slow channel, calcium channel are mainly responsible, as the calcium channel mainly recovered as a time dependent manner. That means if at all membrane potential is reached towards a normal or a resting level, but they cannot stimulated till a specified time duration. So we can say that their effective refractory period is more than the action potential duration. Now you must be aware that autonomic nervous system can also influence the electrophysiology of heart, both parasympathetic as well as the sympathetic nervous system. Parasympathetic nervous system, SN node, automaticity, mainly in a SN node, produce bradycardia. With the sympathetic nervous system, it produces a tachycardia. regarding the refractory period, which is shortened in the atria, both through parasympathetic as well as the sympathetic nervous system. While in a conducting tissue, it is prolonged through parasympathetic and it is shortened through sympathetic nervous system. So when we can say that refractory period is shortened due to sympathetic nervous system, conduction rate is increased. So the conductivity is reduced in a parasympathetic system through parasympathetic system, while it is enhanced through sympathetic nervous system. And when we can say that the conduction rate is increased, contractility is increased through sympathetic nervous system, and contractility is reduced through parasympathetic nervous system. So both parasympathetic try to reduce the uh, heart rate as well as the force of contraction, while sympathetic nervous system can increase it. As the uh, cardiac tissue activity are recorded as an electrocardiogram. Here you can see that as an impulse which is passed on from SN node to atria to AV node to bundle of His towards the ventricle, the different tissue can generate their action potential, and that activity or their action potential were recorded through electrocardiogram, and that is known as an electrocardiogram. With the help of this is a normal pattern. If any abnormality is lies in there, that is easily recorded at which particular site in the heart were affected, their rhythm is altered. So here you can see that the normal electrocardiogram where the P wave mainly represent the contraction of atria, QRS complex mainly represent the contraction of ventricles, and the T wave mainly represent the repolarization of ventricles. Electrocardiogram, you can find out the various terminology. Heart rate basically represent the sinus node automaticity. PR interval starting of P wave towards the starting mid phase QRS complex. So the PR interval represent the total AV nodal conduction time. QRS duration mainly represent the conduction time in the ventricles. QT interval, this interval mainly represent the ventricular action potential duration, and the ST segment mainly represent the plateau phase of ventricular depolarization. There are some important terminology which you must be aware. One is preload, force stretching a ventricular muscle fiber at the end of diastole, that is known as a preload. That is depends on end diastolic volume as well as it depends on a venous return. Another is afterload, forced against which heart has to contract to eject a blood during systole. That is known as an afterload, and that is depends on a peripheral vascular resistance. This is all about the normal cardiac physiology. The take home message is that cardiac electrophysiology is helpful to understand the mechanism of drug which are used for a treatment of congestive heart failure and for a treatment of arrhythmia.